Hey everybody, let's talk about infants and pediatrics and their sleep stages. Sleeping like a baby is a phrase that is super ambiguous. New parents know that sleeping like a baby means making sure that the parents don't sleep all night, and the real meaning to sleeping like a baby supposedly refers to a great night of sleep. Before 2 months of age, sleep looks really different compared to older pediatric patients. You know how bad you feel when you don't get enough sleep as an adult. Now think about how detrimental that lack of sleep can be for a growing and developing child. As adults, poor sleep can manifest as a lack of energy or cognitive impairment, but children experience things much differently than adults. Some children are super hyper when they get tired. It's the hidden effects that we can't see that are so detrimental. During slow wave sleep, or non-REM 3, our brains release growth hormones and they synthesize proteins. When this sleep is disrupted, the child is losing valuable time and consolidation of sleep. This can lead to poor growth or failure to thrive. Uh, Cognitively, sleep disordered breathing issues have been reported to promote poor academic performance. There is also a significant relationship between sleep disorders and attention deficit disorder. Sleep technologists use the same setup of EMG, EOG, and EEG like adults, but with just a couple of exceptions. Because children are smaller, infants in particular, we're reducing the chin EMG placement. Instead of 2 centimeters away, we're going to just break it down to one. And the EOG from 1 centimeter is going to be half a centimeter away and down or up. Before the age of 2 years old, the corpus callosum is underdeveloped, and sleep spindles manifest as asynchronous. The corpus callosum is the part of the brain that puts both of the hemispheres together and coordinates both hemispheres. And asynchronous spindles mean that they don't happen in the same time. Uh, this is um, this is normal for infants. If the corpus callosum is totally absent, this is another good way to tell. The spindles will never be aligned. If the physician is really interested in the spindles, you can use a montage that shows the central electrodes and not just the recommended C3 or C4. But you put those two together with CZ since it's a central component as well. I've never heard of anybody doing that. It's optional. One thing that is always required to score respiratory events in pediatrics, it's always required to have nasal pressure and a thermistor to score these. And, this is pretty hard because a lot of times children do not like that thing in their nose or hanging down. So, this information on uh, patterns and waves comes directly from the scoring manual. Trace alternate and I've got pictures of all this stuff. Trace alternate is a discontinuous pattern, meaning it doesn't happen for very long, and it occurs in sleep. You're going to notice certain things like in sleep. Well, it's going to be non-REM, R sleep, and wake, and sometimes T, which is going to be transition. You can correlate all this stuff with T is N1, N is N2, N3, R is REM, wake, we just have to have different words for it because it's a different kind of concept for smaller people. Trace alternate usually goes away after the first month of life. It appears as bursts of delta mixed with mixed low voltage frequency. So you're going to have these big delta waves all of a sudden mixed in with low voltage frequencies. To be scored, it has to have at least 3 alternating runs, bilaterally symmetric, synchronous, high voltage bursts of 1 to 3 hertz delta activity lasting at least 3 seconds and as many as 8 seconds. Bilateral means both sides. both hemispheres of the brain. And symmetrical means that they're the same length and height. Synchronous means they are occurring at the same time. Remember that high voltage means big waves, big amplitude. Low voltage irregular is seen during R, which we might say is REM, and wake. So it can make it difficult at times to distinguish the two stages of wake and REM. This is a continuous low voltage or small wave, mixed frequency with delta and mostly theta activity. Without delta, I would say. I'll have to look at that. I don't think it's going to have much delta in there, partner. This sounds very similar to slow amplitude mixed frequency that we score with adults with some non-REM and REM. You're not going to have delta waves really in REM. You might have some in wake. High voltage slow waves are continuous, synchronous, and symmetrical, predominantly with big amplitude 1 to 3 hertz delta activity. We see this most commonly with N sleep, rarely with R. Mixed waves are both high and low voltage continuous polyrhythmic. Polyrhythmic means multi-frequency waves. These are intermingled with little periodicity. Amplitude is higher than high voltage slow waves. As we mentioned earlier, sleep spindles are of interest. They only occur in non-REM sleep. They are characterized as 12 to 14 hertz, asynchronous depending on age, and most prominent in the midline central, CZ, and the central derivations, C3, C4. Here are a few textbook examples of each wave pattern, and keep in mind the textbook does not look like the real thing. For one, we don't really know much information about these, where these waves came from, what the ages of the children are. We also don't know the filter setting, which this amplitude does not appear very high for slow waves. It's okay. The morphology, look, those are pretty slow. It's 1 to 2 each one, but it's not very high voltage as far as they're not all the way up here. So that leads me to think that there's a filter on here or they've turned the gain down. Pediatric brain waves are gigantic. A lot of technologists will turn the zoom down to better view the waves because they can interfere with each other. But you can see that there are bigger and longer waves in the top group compared to the lower three. The only exception would be trace alternate, but that isn't continuous. It only happens in bursts. One here, little low amplitude, then another burst, low amplitude burst, maybe right there. Low voltage irregular, to me it looks a lot like LAMP, low amplitude mixed frequency. Not a lot of patterns in here. There's maybe some theta there, one theta wave there. Not much, very low frequency. In fact, I think this is really low. A native signal or a signal that comes straight out and has no weird filter settings or gain settings is going to look like that. That's very low amplitude. Lots of theta there, low amplitude theta. This happens in REM and wake and some transitional sleeps for adults as well. Mixed might have some delta waves. Boom, 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 boom. But there's still more theta here and less than theta. Some right there. And again, trace alternate is the bursts of delta waves. This is from a record I ran several years ago of a 6-month-old. So it's a little older than 2 months, but these are native waveforms, meaning the filters are unchanged from all the adult montages. They're huge and they go beyond the margins, as you can see. Here's some of these waves. Here's where the margins are, and that equals 100 microvolts. So these are gigantic waves, and they go all over the place. Uh, they're so big, in fact, the EOG picks them up. Whenever you see big waves like this in EOG, the eyes aren't moving. Those are just brain waves. Uh, EEG artifact, if you will. These waves are so big, in fact, they almost resemble a sweat or sway artifact. Um, but sweat or sway artifact is when the entire baseline of the channel is swaying and not the waves. These waves are going up and down, but there's always this averaged line that goes through the middle of it. Here's sweat artifact. As you can see, here's some EKG artifact to see that it's going all, the baseline is moving all the way up here and all the way down here. These, they kind of look like slow waves. They might be having some slow waves, but it's hard to tell because the baseline is going all over the place instead of staying straight. It's going all over the place. That's when. So what is this? This is there are many kinds of names for this artifact. Just like in all things sleep, delta waves, slow wave sleep, N3. So many names for different things. Uh, this is I personally call it sweat artifact. Notice the EOG amplitude and the O amplitude. Uh, and especially up here in the C's, this is probably the most of it. The patient is sweating, and when sweat mixes with the melted paste, it can electronically short circuit the signal. It's also called salt bridge artifact. Salt is what's in the electrode paste to make it conductive. So sweat, also being conductive due to its sodium content, connects the two electrodes, and the differential amplifier interprets these as large waves going from this side of the brain to the other. So you can see how there are smaller waves riding these bigger waves, maybe low amplitude. There's some nice ones, but it's riding these big waves. That's the difference. How can you get rid of this? You can turn on a fan. You can use air conditioning. Take some of the covers off. You could also limit the low frequency filter from zero point 0.3 to 1 hertz. However, that can limit the actual delta waves the patient is having. So do everything you can physically with the patient first to make the recording as perfectly as possible, and then you can tweak filters here and there. Just remember, the more you tweak, the less native the signal is. Infant staging to me is a lot like other sleep staging, like I said. The amplitude is much increased, and the architecture is a little different, but they still have wakefulness. They still have REM, stage R. They have non-REM, stage N, substituting non-REM 2 and non-REM 3. And stage T is non-REM 1. I think the main reason we do that is because infants do not exhibit spindles or K complexes the way we're used to seeing them in adults or even older children. Trace alternate kind of resembles the vertex sharp waves seen in some patients as they're falling asleep. But in short, we use these stages because we don't see a lot of normal signs of stages as we do in adults. Uh, it's really the same sleep, it just looks a little different. The first REM period can be quick and hard to spot if you're not looking closely. So when we look at the record of an infant, you will notice certain things in the waves while they're awake. You will notice an absence of alpha waves if their eyes are open. The video will also show if they're moving around. There should be some movement artifact in the EEG. Native EEG signals should show low voltage, irregular, and mixed frequencies. The EOG can also show scanning eye movements and blinks if they're still enough, as if they're not moving around. A lot of patients have to keep still for you to really read things. Also, consider how their respirations are being monitored while they are asleep. The belts really only work if you're still and really well fitted. They're going to be squirming around and moving and crying, so it will appear that their respirations are kind of crazy. But a lot of that could just be movement artifact in the belts. However, when they do settle down, their respirations still are not as rhythmic as adult respirations, so it's expected to be a little asynchronous. It's also important to keep track of where the belts are. Location is key to indicate paradoxing effort. If you're not sure if the belts are on right, they both could have slipped down to their waist. You want one near the belly button, one near on the chest. Stage N for infants visually looks like their eyes are closed. They don't move very much, and sometimes suckling can occur. If you've ever held an infant and felt them fall asleep, you can sometimes feel them twitch. We call those hypnagogic jerks, going to sleep. Hypnagogic, that's how I remember. Hypnagogic means going to sleep. Theoretically, your body is falling asleep, but your brain isn't ready for it yet, so it quickly arouses you with a jolt. Sometimes these jolts are subtle, but you can still see them in the EEG and the EMG. Suckling is an evolutionary byproduct. A lot of babies go to sleep on milk, and so they just continue doing that. Also, maybe a self-soothing thing. That's why we have pacifiers. Respirations are also regular, unlike a lot of wake and phasic REM. You may witness children and adults, for that matter, occasionally sigh while they sleep. There are a couple reasons for that. The first theory suggests that the carbon dioxide feedback loop has to be reset, and a deep sigh is the result. This is similar to many end-tidal capnographs. They have to kind of reset or recalibrate the carbon board in order to get accurate readings. You'll see this in a recording where the capnography is not 35 anymore, it's like 70 or 111. That's getting recalibrated for that moment. You have to band all that stuff in the record as artifact, or else the baby looks like they've had this tremendously high CO2 reading. Uh, the other relates to lung issue becoming stagnant when we sigh, because when we're sleeping, the respirations are only so deep. Our tidal volume is that's all. And so a big sigh essentially stretches out the lung tissue and keeps them more pliable and flexible, and potentially allows for more alveolar recruitment. If the alveoli are open and have access to air, they can assist more with gas exchange. When infants are in REM, remember it can be difficult to discern the first REM, but their eyes will be closed. You can even detect their corneas rotating under their eyelids. It's also normal to have small movements in the face or limbs, as long as they're not repetitive and cause arousals. In REM, you will see lots of irregular breathing, and I'll talk about why in a little bit. A lot of times, those will occur in phasic REM, which I'll also talk in a couple more slides. The EEG will be low voltage or regular, very similar to low amplitude mixed frequency, LAMF, and rarely will high voltage slow waves occur. Be careful that if you do see big waves, especially in the FPs and the Fs, they're so close to an infant's face that they could be eye click artifact and not waves. If you come across epics of infant sleep that doesn't make sense to score it as REM or non-REM because of the EEG, but you can tell they're asleep because they're not moving and their respirations are fairly normal, uh, you can score it as transitional. But if only half of that is transitional, you want to score the rest of it as whatever else it is, like either wake or non-REM or REM. You want to go on and score that instead. An infant's first stage of sleep, besides transitional, uh, they start dreaming immediately. They go to sleep in REM. Adults have to build up to it, but infants get to it right away. Their sleep cycles last somewhere between 50 and 60 minutes in comparison to the 45 to 90-minute sleep cycles that adults have. Half the sleep time will be active, which is an old-fashioned term for REM, and half the sleep will be quiet sleep, which is an old-fashioned term for non-REM. We used to stage infant sleep as wake, active, or quiet. We also used to score uh, past stage 3 called uh, stage 4, non-REM 4. And I think there's something to it, but now we put all that into N3. As the infant develops, REM percentage will increase and REM latency will also increase. REM percentage decreases REM latency will increase, meaning how long it takes them to get to REM. We expect normal infants to sleep somewhere between 12 and 16 hours a day, 12 hours at night and probably 4 hours somewhere in the day napping. 1 to 2 year olds, they'll sleep somewhere about 12 hours a day, uh, maybe a daytime nap. 3 to 5 year olds, somewhere between 10 and 13 hours. Children stop napping earlier, maybe around 2. Some continue on till 3, but if they do, those nap hours can be shifted to nighttime sleep. It really depends on the sleep needs of the child, but sometimes also comes down to the convenience of the parent, you know. Between 6 and 12, it's 9 to 12 hours. 13 to 18, it's 8 to 10 hours. And adults, you need more than 7 hours, optimally all at night. Adults that nap during the day reduce the sleep pressure that allows them to sleep all night, especially if you take a nap after 2 p.m. and trying to go to bed at a normal time. This is kind of what a hypnogram looks like after you've staged all of the sleep. It kind of looks like this. You go into 1, 2, 3, 4, and arousal goes back to REM later. This is different from infant. Infants would come right into REM. Here's REM, and then stage 4. REM increases. Lots of stage 3 and 4. Remember that stage 4 we were talking about? That's just stage 3, like on steroids. It's just that picture I showed you earlier would have been uh, stage 4. Children's brains give off huge amplitude or high voltage with their waves. Uh, Sometimes your protocol will call for you to reduce the zoom or the gain on the EEG so that they're easier to read, and that's normal. Some adults do have significant amounts of slow wave sleep, but they won't have the amplitude nor the duration. Slow wave sleep is believed to be a function of growth and physical development when growth hormone is introduced. Children are literally growing when they sleep. When we're looking at patients 2 months and older while they're awake, the voltage is still much higher than adults. When the patient is lying still with their eyes open, you should be able to detect a slightly more rapid alpha. When their eyes are closed, the alpha should really slow up in greater amplitude. We refer to the occipital channels when we look for alpha, but it can be seen in the other channels as well. The O's are the center of the anatomical oscillator that produces that rhythm. An oscillator is a piece of anatomy that goes back and forth, and that's why we see the rhythm like that for alpha. Chin tone should also be relatively high. You should see eye blinks. Alpha should dissipate or attenuate with eye closure. Score an epic as wake if 51% of the epic is made up of alpha. All right, just like adults, stage 1 or non-REM 1 is transitional sleep. It transitions the brain from wake to sleep, and sometimes from sleep stage to sleep stage. For N1, the signs include slow rolling eye movements. Check this out. Slow rolling eye movements. That's it right there. Uh, you can see that under this red box here. The EOG signals are deflecting away and towards each other slowly. As this happens, nice alpha waves right here. Look at that, this nice big amplitude starts to go away right there. And they turn into really small alpha waves that are giving way to more waves. See how this rhythm goes away, starts to melt right there into smaller waves. That's sleep onset. That is someone falling asleep. You can see that in the red box. You may also encounter vertex sharp waves, which sit on top of the baseline. Background EEG exhibit rhythmic theta in the anterior or front of the brain. F. Here's a little theta, there's a little theta, there's a little theta, maybe a little theta right there. In REM, we get lots of LAMP, low amplitude mixed frequency, sawtooth waves. And you'll also see the lowest chin tone possible from the patient on that night. Rapid eye movements or eye clicks and some irregular respiratory activity. First, we should set the distinction between phasic REM and tonic REM. Tonic REM is just regular old low amplitude mixed frequency, no chin, no eye activity. Phasic REM is when the eyes look around, and also when the respiratory effort might be strange. And we think of it in evolutionary terms. When we were lower on the food chain and we lived in huts, we had to stay vigilant at night to ward off any nasty creatures. We didn't have security back then or anything like we didn't have a good house to keep us safe. So when we heard a sound that startled us, we would look around with our eyes. And you may notice when we do that, we'd take a big breath in and hold it. What was that? We are putting all our energy towards searching with our eyes that we are holding our breath. And it also provides us with more stealth so that prey or enemies can't hear us. Uh, we can say the same things are happening in our dreams. There are times when we hold our breath, start to breathe erratically if we cry or we're laughing. So irregular respirations in REM will happen. However, they will usually occur in phasic REM when our eyes are moving around. This is also true for REM central apneas. Since these apneas are our brain actively mimicking what our dreams are doing, is that something we can really treat? Do we treat central apneas in REM? Well, that depends on the physician. If they are super long centrals with horrible desaturations and arousals, then maybe, yeah. The respiratory drive switches from one part of the brain to another while we dream, so we expect some irregularities. This doesn't have pressure. It's just good enough to score respiratory events in pediatric patients. Which you can't see that, but it had some respiratory stuff down here and it didn't have the flow, so you can't see that though. Here's some eye clicks. That's what the blue lines are showing. Either going away, they're pointing at each other, and then they go away. They're away, then pointing at each other. This is a pretty good example of REM. Check out how low amplitude the waves are in the O's right here. These are right at the back of the head, so it's not near the eyes. See these waves up here, and the C's and the F's. Those are eye clicks. So those are close enough to the eyes that you're getting some of that from the eyes. Those aren't waves. Those should be flat like this. So those are eye click artifact. Uh, Another note about eye clicks, and sometimes EOG can be hard to read, especially if the electrodes aren't properly placed. It can make one side have greater amplitude than the other. But if you take like a piece of paper and you hold it straight, you can tell if they're actually eye clicks or if they're just waves that kind of pop up. Here's a good example of sawtooth waves in REM. Boom, boom, boom. They look like little sawtooth waves. They're just pointy. And then they sometimes have little tiny waves after them. Boom. Looks like you would get cut by those sawtooth waves. This is tonic REM. No eye movements. Here are some good examples of sleep spindles. Every blue arrow points to one, a run of them. Notice they are all happening at the same time, synchronously. They don't occur in one lobe and then another. They're all right here, right here. We're not having some here and then some here. That's indicative of a good corpus callosum. Spindles are poorly formed, around 4 weeks old, but they'll reach mature quality by 2 to 3 months post term. They're usually in N2, rarely in N3, and sometimes in REM. Spindles, we believe, are functions of keeping us asleep by muting our brain's reception to environmental noise or action. That's when or why you may see something called pseudospindles. Those are fat spindles. They're longer spindles, and they can sometimes last longer than 3 seconds. Those occur when people who are on tranquilizers sleep. the tranquilizers really separate your brain from responding to things that are going outside. And that's the brain showing us they're very asleep. This is a pretty good example of a K complex. One thing I want to mention about K complexes, if we put an imaginary baseline right there, that's 0 microvolts, right? You'll notice that a K complex kind of starts at the baseline, deflects up, and because it's EEG, that means it's a negative deflection. Everything's backwards. It goes up, and then it goes down through the baseline. Starts the baseline, goes down through it, and then comes back up to it. That is a K complex. It's got to do that. Some things like vertex sharp waves, they look like this, or like kind of like that. Um, that's not a K complex. It's got to go above the baseline and through and back to it again. It's also common to see spindles after a K complex. These typically appear somewhere between 4 and 6 months post-term. We score N2 with the presence of K complexes and/or sleep spindles. Here's that delta again. There are a bunch of names for N3. Slow wave sleep, delta sleep, high voltage slow waves. It's all the same thing. Just like posterior dominant rhythm is kind of like alpha, right? Uh, these begin to show around 4 to 5 months post-term, and they're scored N3. To score M3, delta waves have to be present for at least 20% of the epoch. The way I score M3 is I look and see if there are like 6 waves that go beyond both margins, especially if these margins, like right here to right here, was 100 microvolts. If it goes from there to there, that's perfect to score N3. Um, the less spindles, the more likely that you are in N3. If you're on the ISR, and I'm going to do an ISR video sometime, they'll get out their measuring tape on the computer and measure each one, but that's totally unrealistic in scoring sleep professionally. It's a good way to show you how we find slow waves, but it's not something you do every time. It's more about the morphology of the record, and that's really what tells you the stage is looking at it and knowing if you've looked at records long enough, you can just look at it and tell. All right, let's break down this term again. Hypnagogic. Hypnagogic, as in going to sleep, means something's happening when you're going to sleep. Hypnopompic is the opposite. Something happened when you wake up, right at the end of sleep. I think hypnagogic and hypnopompic. When I think of hypnopompic, what's the song that they play at graduation? Pomp and circumstance. You graduate at the end of your student career. End of sleep. Hypnopompic. That's how I can remember both of those. Hypersynchrony. Hyper means many or elevated. Synchrony means things happening at the same time. You can see in the figure there are these bursts of what look like big alpha waves, but this is hypnagogic hypersynchrony and occurs just around or after sleep onset. It just shows up around 4 months of age. Let's talk about capnography. There are a few additions to pediatric studies. For instance, capnography is the collection of carbon dioxide data. Why do we always add capnography to pediatric studies? Children are less likely to show oxygen desaturations and more likely to show arousals and hypercapnia, or too much CO2. Hypercapnia is more common in children, as are respiratory problems. That's because the respiratory problem or respiratory system is one of the last things to develop in children. Pediatrics are more susceptible to respiratory failures. Just think of SIDS and back to sleep. The back to sleep was the movement to place children on their back to sleep instead of on their sides or prone. Children lack the nervous system arousal response that has developed in adults, so they don't arouse when they aren't breathing, and that can kill them. If you remember in CPR training, you immediately start compressions on adults, but children, you give breaths. The underdeveloped respiratory system is the reason why. Children are more likely to have respiratory problems than cardiac. And with reading capnography, we say Normal range is between 35 and 45 millimeters mercury. That's how we would say that, or you can just abbreviate it in mmHg. When the patient is asleep, we expect certain normal vital signs. First, the SaO2 should remain steady above 92. 92 is still kind of low for a normal and healthy individual, but for standard's sake, you got to consider it normal. Uh, the maximum desaturation should be no greater than 8%. Really, you don't want any. The maximum readings on capnography is 55 millimeters mercury. There are a couple other standards on capnography, such as the max shouldn't be 10 to 15 millimeters mercury than the average reading. Also, the amount of total sleep time is considered. You want to see less than 10% of the night of sleep uh, with more than 50 millimeters mercury and less than 60% of sleep time with more than 45. Regular CO2 values are going to be 35 to 45. That's a good way to know if it's an artifact or not, if you're not getting enough CO2. Usually 30 is kind of low. There are a million reasons to keep a synchronous video record when running pediatric studies. You want to know when things are happening during the study as it's going. It can help determine if a kid is pulling off the wires, if a cannula is still placed under the nose, what position the patient is in, if the patient is really moving their legs or having nightmares or parasomnias. Also, it's good to know how their parents interact with the children. Sleep hygiene has to be on the parent in this situation because a child can't put themselves to sleep. And again, you'll have all kinds of parents. The kind that will sleep in the bed with the child, the ones that will lay in the bed or sit in the chair and be on their phone all night, and the room fills with that really bright light. Some even talk on their phone or watch videos. So it's up to you to document everything that happens so the doctor knows the whole situation when they read these reports. There are also some conditions such as PIRCM, which is when children who sleep supine have this paradoxical effort. This is debatable. Children's room cages are very compliant, and they're going to naturally do that sometimes. The important thing is if you see that they're losing airflow signal because of it, and the paradoxing becomes greater or lighter in amplitude, and they're arousing because of it, and if they're having desats, then yeah, you want to do something about it. But if you notice nothing at all, uh, but you notice that the belts were in sync and now they're not, uh, and it ends with an arousal or going back into normal in sync, then that's probably it too. Also, a lot of children sleep with their head way back. Sometimes this can be protective against sleep apnea. Sometimes that's just how it sleeps. I've seen lots of kids sleep that way and it's no big deal. If you notice it, document it. Even if the patient doesn't have events or anything, the doctor should know, and they should be aware of it. One of the easiest patients I ever hooked up was an infant at 16 weeks old. They don't have any fine motor skills, and their arms are too short. They can't reach to the top of their head and take electrodes off. This patient just laid there while I was able to mark very gently, making sure not to hit uh, the frame, not the foramens, what am I? Their soft spots. And because the patient had such little hair, I didn't lose the mark. Also, with babies that small, I put the electrodes on without scrubbing, and the impedances were perfect. Small children don't really need a lot of scrubbing, very young children, because they have such nice skin. But it's always a good idea to have an impedance meter to check if you do need to scrub more. Some of the harder patients I've had were 3 to 4 years old. These children are just big enough and just strong enough to take everything off. And the worst is when you go to their face to put something on and they push your hand away. Oh boy, I'm patient, but nothing got me hotter than that. It always helps to have the parent there, but sometimes they can be difficult too. Every patient is a totally different possibility, but you can preempt some of the pain if you prepare with some knowledge and lots of bluey. So these are the recommended technologists to child patient ratio. Technologist to child patient ratio. If they are 5 years old or younger, it should be one-on-one, one tech to one patient, as it should be with any other special needs patients. We're talking about people in wheelchairs, people with mental disabilities, Down syndrome, low IQ, post-stroke, morbidly obese who needs a Hoyer lift. or children with autism, things like that. Between the ages of 6 and 17, patients are generally old enough to tolerate a sleep study without needing more intervention. You can do a 2-on-1 there. One other thing to consider it would be if the technologist also has to perform like a split night or a complex PAP titration or has to switch out a bunch of masks just to find the right one on another patient. That could be a 1-to-1. Hopefully, the lead technologist in charge will delegate properly and no one gets stuck with a hard titration in a 2-year-old. I've personally run 4 patients before, one pediatric, a split, a CPAP, and a regular in PSG because another technologist didn't show up. And I was kind of a pushover with patients back then, but there's no time to do anything after you do that. You don't have time to talk to the patients. You only have enough time to hook up everybody, run the studies, and take people to the bathroom, get the people up, clean up, and then leave. Regularly ran 3 patients at Raleigh Neurology, and a lot of times those patients were under 6 years old. Those are recommendations, and they're not requirements to run 1-to-1 or anything. But you have to consider safety. You have to consider how good you want your studies to be. Do what you can to make the sleep lab in the child's room more inviting. You can do what's listed here with fun decor and vibrant colors, but remember that the child is here to sleep. You absolutely need to childproof the room. They will grab and climb and eat everything they can get their little hands on, especially in the fun drawers that we sometimes keep supplies in with the CPAP machine next to the patient's bed. Also, if the patients have bathrooms that lock, you may consider disabling that lock. You don't want a kid to lock a kid themselves in the bathroom and you can't do anything to get them out of there. You don't need to be a kindergarten teacher and speak with them with total inflection. Goodness, we're having a sleepover. But you can speak to them in a friendly way, as if you were talking to just a person. Because that's what they are. Access to a refrigerator and microwave is nice. I've had patients that needed medication or mother's milk to be cold throughout the night. You can use words like, oh, we're having a sleepover instead of a sleep study or sleep test. Your lab dictates rules on food and if they have a TV or DVD players that a patient can use. I think an issue with movies, especially long ones, is if it's time to go to bed and the movie's not over, the patient's going to get upset and you've lost sleep time and maybe a few wires. You got to use your own better judgment. Give the parents information on when the study will be ready. They're usually shocked to find out it takes about 2 weeks to get the results and an appointment. Have the child bring a stuffed animal or pillow or blanket. You might have a white noise machine. They can block out a lot of noise if the kid's easily awakened. Night lights are great. Even get one of those salt lamps. Those are really popular. So, in the end, kids are little adults. They don't have impulse control. They can't stop themselves. And they don't have a lot of experience, but they still feel scared. And you remember how that felt, right? How do you remember when you were a kid going to the doctor's office when you were small? Try and think of things that you as a child would find comforting or reassuring. What was some of the fun things? Maybe that little game with the beads it's like a little track and everybody gets sick off of it. Let them play with a bundle of old wires. I used to have a bunch of really old wires that were all tangled just for that reason. They can mess around with them. Tell them that you're putting on a crown of gold because the electrodes are made of gold. Reassure them that the tape is going to come off and absolutely have adhesive remover on hand for the tape. That's an easy thing to do to increase the comfort of everybody. Be patient taking the wires off. You don't want to hurt them. A lot of little ladies and some little boys too have lots of hair, and you don't want to rip them out. Some kids are tougher than others, but some will cry at the drop of a hat. So just looking at them. So you got to be careful taking stuff off. All right, that was a long one, but it's done. Well done. We'll see you next time.